We are at Uppsala University, where the U-fold has been introduced today, and one of the speakers here is Mary Jeanne Creek, professor at the Rockefeller University in the United States, and a very well-known international scientist specializing in treatment of opiate addiction. Welcome to WFAD. So, what about your work on opiate addiction? What do you think would be the most important thing to tell the international community today?
Well, I think there are three messages from my earliest work in 1964, when I was part of the newly assembled three-person team to see if we could develop a more effective treatment for heroin and other opiate addictions. We developed methadone maintenance treatment based on our observations and later scientific data that methadone is orally effective in humans, long-acting, and could be used as a replacement treatment, but causing no euphoria or high and preventing withdrawal symptoms. More importantly, I think what we learned in that earliest research was that addictions are diseases of the brain with behavioral manifestations, and they are not simply criminal behavior, a weak personality, or some type of psychiatric disorder. And this is extremely important, and this now I would say pertains for each of the major addictive diseases: alcoholism, cocaine and amphetamine addiction, opiate addiction, including, of course, heroin addiction. Treatment works. So my first statement based on that early... So my first comment would be treatment works, but we have to constantly conduct more science and clinical research to see which treatment works best for whom, and to develop treatments for those addictions where we don't have any highly effective treatment. Methadone is effective in 60 to 80% of unselected persons and is very inexpensive. It is being used to treat over 1 million persons successfully worldwide. If high enough doses and proper combination with counseling and medical care are provided, then the effectiveness goes even higher. Buprenorphine, a cousin of methadone, is effective in 40 to 50%. But we know that other medications aren't so effective, and we've learned a great deal about the biology. So the next thing is to use what we've learned in both laboratory work and clinical research to help guide policy. The need for treatment, the need for establishing more treatment programs to get new treatments for those disorders that we don't have good treatments for, and also, in fact, to be sure that we have the most effective doses. We've now learned in our genetics work that we can even predict what kinds of doses of methadone are needed on a genetics basis. The third message is we have to be a little bit less judgmental. Huge numbers of people have an addiction. They all deny it. It is still the most stigmatized of the disorders. We have to pull away the stigma and say, look, we're talking about a disease which, like most human diseases, have genetic factors, but also environmental factors. Now, you won't develop an addiction without the drug. But on the other hand, you can have gene variants, many of them, combining together to enhance the chances or maybe protect from developing an addiction. We also know that drugs of abuse change the brain in ways that are very long-acting, persistent, and in some cases may be permanent. So a person doesn't have to have the genetic vulnerability to develop an addiction. I'm frequently asked, once you solve the genetic complexity for addictions, will you have a test that says it's okay for you but not you to use drugs? No, because we know we can take any rat or mouse that doesn't like to use drugs and change their brain and make them use drugs regularly on their own. The same is true in humans. We see this, don't we? When you have campuses where children drink much too much alcohol, or places where peers are pressuring people to use opiates. But on the other hand, genetic factors can make a difference, and they can make a difference in even selection of some other therapeutic agents. greater caution would be used in some cases, for instance, in prescribing opiates, which we need to give to people who have cancer or some terrible disease, but we need not to overuse when a person simply has a dental repair or fracture. Legalization is a question you could ask me about, and I believe that my earliest concepts about this, and those shared with the late Marie Neiswander, which was part of our 3-person team, was we're stuck with one drug that's part of our society, part of our religious, cultural events. That's alcohol. And in the Western world, Europe, U.S., alcohol use is part of the social and religious context. Prohibition didn't really work. It caused all kinds of problems. But we don't really need to legalize even a drug which some protest, and they may be correct, might be safer, which would be marijuana, for instance. We don't need another drug where up to 20-25% may become addicted to that drug and have their life ruined by it. I don't think we need to legalize heroin or cocaine or amphetamines either. We saw when the cartels that manufacture cocaine became aware of our very earliest work in 83, 84, defining the second risk group for AIDS infection being drug users and cocaine users, especially parental drug users. They made a form of cocaine called crack cocaine, which is nothing more or less than cocaine with baking soda that makes it a free base. But this form is able to be made very cheaply. So we found on the streets of New York, only the affluent could afford the old-fashioned cocaine prior to 85. And after that, any youngster can buy cocaine on any corner for less than going to a movie or buying a candy bar. And what we saw was a soaring of the number of people using cocaine. Right now in the U.S., we're experiencing an epidemic of illicit use of prescription opiates. It was wonderful that the pain world was able to convince physicians you need to treat pain, especially, as I've mentioned earlier, malignant pain, chronic pain. But on the other hand, we don't need to give 14 days of a strong opiate, like Oxycontin or Vicodin, or Methadone to people who are opiate naive and simply have root canal work or fracture. We have to be more careful because when you overprescribe, you have medicine cabinets full of drugs that youngsters can access and are accessing. And then they become illicitly trafficked, and then the youngsters change to heroin because it has greater effectiveness. So I think we have to be very careful about racing to legalize drugs of abuse. We have to do a better job in prevention. We have to get rid of stigma so people with addiction can come into treatment, so we have less people vulnerable to help sell the drugs for the cartels because they're addicted and will be paid with drug. We need to have a society that accepts the fact that each of us have genes for diseases that are going to catch up with us sometime, and we have to accept that, but work with prevention and then work with early intervention and work with treatment.
So would you say then, just to close, that moving towards more medicalization is the way forward?
Absolutely. I think we have to do that. Right now, most university hospitals do not have an addiction treatment clinic. Not in my country, not in Sweden. And that needs to change. I've been proud of the University of Uppsala because they've always had treatment programs. I've been proud of my university, which is a special research university, because they welcomed our pioneering research in 1964 and still welcome my research, where I bring active addicts onto the ward of our research hospital. We have to have more medicalization, but that does not mean just physicians. It's nurses, it's counselors working in a proper mix. And we have to have an integration so that, as I pointed out, the most common cause of hepatitis C is drug abuse sometime in life. But a higher percentage, we have recently found, of those with hep C actually have drug dependence, undetected, untreated. Well, the doctor who's treating hepatitis has to be able to bring people into treatment for addiction straight away in their same facility. We cannot have the drug abuse treatment clinics often some dark little alley in a bad area or under such stigma that people are embarrassed to say they go there. We have to bring these diseases to the forefront.
The use of prescription of heroin, which is being carried out. It starts in Switzerland, Professor
Switzerland, Netherlands, and Vancouver.
Germany, Vancouver.
Yeah. Well, I will tell you, I was on the jury in the Netherlands, and at the request of both the NIH and the Netherlands government, and I heard all the predictors, but one very funny thing, they said they were going to start with people who are resistant to methadone treatment. Mm-hmm. And I learned the most common dose of methadone was 40 to 60 milligrams a day. Back in our earliest work in 1964, we said the proper dose would be 80 to 120, and now in 2011, we say it's 80 to 150, with a purity of heroin going up, because these low doses don't protect against superimposed heroin. Well, the Dutch government listened to me very carefully, and they did a separate study while the heroin substitution study was going on, and they found indeed I was correct. And now the doses, I'm proud to say, in the Netherlands are 80 to 120 or 150, and they have many fewer people, quote, failing in methadone treatment. The other thing I recommend the Dutch government, which is, I've been to the program in Switzerland, but 2 of them, and I think they started with good intention. Do not misunderstand me. Dr. Unterhagen down in Switzerland was very, very well-meaning and motivated, but it just didn't quite work. And in the Netherlands, it's probably worked better because they're very compulsive, but not known to the public is persons come in for their heroin to a center, and it costs approximately $100,000 a year per person to treat this way. And at the center, they may get either nasal or intravenous heroin. They can come in not more than 3 times a day, and the maximum dose is prescribed. But they also get methadone for overnight to prevent them from going into withdrawal, and methadone every weekend. So it should be called a methadone program with heroin substitution added. But is that really needed? Well, it may be for some people that refuse to give up the euphoria or the high. And what I have found as I return frequently to Amsterdam and Utrecht is that many of the people that come in for treatment will start decreasing the number of times they come into once a day of heroin. And they'll go overnight, they're in relative withdrawal, they'll take the dose of heroin, get a high, and then take the methadone for the rest of the day. Well, that's not very good either, and many of them begin to think, well, maybe I'd rather go to work full-time or have a family. So I suggested to the Dutch government, and I'm proud of them, they've done it. The most recent new program in Amsterdam is in a brand new building in a rough part of town, and it's a police station. And on a low floor, they have both the methadone clinic and heroin substitution in the same facility. So the heroin substitution people see the people receiving methadone do so well. And little by little, they transfer. So I think if you're going to do it, you ought to do it right. I've been horrified with the Vancouver papers, the New England Journal, because clearly many things were not attended to. And if you look at the data carefully, it was quite different in Ontario, within their own country, compared with British Columbia. And the German program really has not been rigorously presented yet. So I can't give you the results. Do I think it's needed? Maybe for a few people, very expensive. I'd rather see us get out there and offer more enhanced counseling and proper doses of methadone, and be very sure that if we use buprenorphine, which is a splendid medication, we realize it is a partial agonist. So you cannot get up to a dose equivalent to the usual dose of methadone.
What about the risk of diversion then of all these substances?
We've had none. There was a huge concern about this in the early 70s in the U.S., and one of our presidents spent, I think it was $3 million in 1973, looking for primary methadone addiction. They found 3 in the United States. You can find 3 on aspirin. I mean, easily, many more than that. So it's a non-problem. But the reason, and I mentioned in my lecture here today, buprenorphine, if it's injected, gives a high. And methadone, if it's injected, and we did those studies when we were doing the kinetic studies in the early 70s, it doesn't give a high. Why? My lab went and insisted on finding that out. It binds to plasma proteins, and then it binds to the liver. And it's slowly released you have a sustained release capsule that's your liver. And we found that people with shrunken livers due to cirrhosis actually needed more methadone, not less, because their liver wasn't holding enough methadone to release it gradually. So these are extremely exciting findings. And what it tells us is that if you have a boring drug like methadone, that you will not get a high, and diversion will be very unlikely. And we knew when we first developed the program that addicts would use what they called dollies, dolphin hydrochloride, the trade name for methadone way back then, which was very modestly used for pain management, but they'd use it only to prevent withdrawal if they couldn't get any other opiate, no morphine, no Demerol, no heroin. Buprenorphine, we suggested early on they should try what we did early on with methadone and found it was unnecessary, but add naloxone. So if a person should intravenously use buprenorphine, abuse it, and had the naloxone there, it would prevent any high. And that's worked beautifully in U.S. And the French government just 2 years ago turned 180 degrees and no longer allows buprenorphine. It has to be buprenorphine naloxone. They had such a huge abuse problem with buprenorphine. I assume, I know that Sweden went immediately with the buprenorphine naloxone combination, and they in fact put exactly the same regulations in Sweden on methadone and buprenorphine. They've had no abuse problem, no leakage problem. I think this is extremely important, and I applaud the Swedish model. We have much stricter rules, as do many countries, on methadone compared with buprenorphine. We haven't yet seen a major abuse problem with buprenorphine in the U.S., but in some cities we are seeing it, and usually it takes the form of someone who's been not doing well in methadone or not doing well in other treatment programs, suddenly showing up at a pain clinic and developing pain and being given 30 days of buprenorphine without naloxone to take home. So I think we have to be very careful, but I think having treatment there is so important, and the abuse is so low if you have methadone or buprenorphine naloxone that we really need to stop perseverating over that. We in U.S. and you in Sweden believe it's great for people to get back to work, back to school. Some call that puritanical, but I call puritanical only when you say people don't deserve treatment. That's kind of weird. That's not what we believe as a people, and not in Sweden either. We need to offer treatment along with prevention, and I think one of our goals should be early intervention.
Thank you very much, Professor Creek, professor at the Rockefeller University in the United States.
And head of the Laboratory of the Biology of Addictive Diseases, which I'm very proud of, obviously, and which our two most recent presidents, Mark Tessier-Levine, current president, and Sir Paul Nurse, now head of the Royal Society, have been extraordinarily supportive of our work, just extraordinarily supportive. They understand the need for science to guide policy and evidence-based medicine to guide healthcare.
Thank you for talking to WFAD.
Absolutely.